patients who have dual cannula tracheostomy tubes, it is important to inspect the inner cannula frequently. Change or clean the inner cannula once or twice daily or as needed. Suction as needed and when indicated by breath sounds. Teach the patient how to cough and deep breathe and how to mobilize secretions. For patients who have single cannula tracheostomy tubes, it is critical to provide adequate humidity using both internal and external humidification to reduce the risk of tube occlusion. Suction the inner lumen to keep it clear of secretions. Teach the patient coughing and deep breathing and how to mobilize secretions. All of these measures allow you to proactively ensure the integrity of the inner lumen of the airway. When performing tracheostomy care, always use universal precautions such as gloves, an appropriate mask, and shield for your eyes. These precautions reduce your exposure to infectious agents. Preparation for emergency tracheostomy care is part of standard care for tracheostomy patients. A post-tracheostomy tray should be at the bedside. You should also have extra tubes available. Most common practices recommend having the same size tube and one size smaller available to facilitate replacement in the event of occlusion. You should also have suction catheters and suction equipment available, along with a resuscitation bag with a tracheostomy attachment. If you're unable to pass the suction catheter through the tracheostomy tube, attempt to change or clean the inner cannula first before calling the physician. It is important to gain physician assistance if the faceplate or flange will not remain flush with the neck, as this may indicate incorrect placement of the tracheostomy tube. Finally, call the physician if routine care does not resolve any respiratory distress. There are several alerts that should trigger consultation with a physician, your mentors, or expert nurses. These include purulent secretions, a pressure sore from the flange or faceplate, and formation of any granulation tissue at the stoma site. Other examples include soiled dressings that you can't keep clean or an unusual odor from the tracheostomy tube. These may indicate an underlying issue that needs to be addressed. As frequently as necessary, use a cotton tip applicator with a cleaning solution to remove secretions and debris from the wound site behind the flange or faceplate. When should the tracheostomy tube be changed? It is common practice to change the tube at postoperative day 5 to 7. At this point, the tract should be established. Before discharge, patients should be taught to change their own tracheostomy tube. Research has found that frequent changes of the tubes themselves may prevent biofilm-related infections. Please note that manufacturers do not specify frequency for changing the tracheostomy tube because of variations in patient needs. However, most manufacturer directions for use state the use of a tracheostomy tube should not exceed 29 days. Let's review evidence-based practice for suctioning, humidification, and saline installation. For suctioning, only suction when patients are unable to adequately clear their secretions. When patients are able to do so, teach them to cough, deep breathe, and clear their own secretions. Address the patient's requirements for humidification. Counteract the effects of insensible water loss by monitoring water balance. It is important to address internal and external humidification. Saline installation is controversial, but may be appropriate for selected patients. The literature clearly demonstrates that saline installation into the lumen of the tube is not to be done with ventilated patients, but the literature and expert opinion clearly supports the use of saline installation for spontaneously breathing patients. As the patient progresses through speech and decannulation protocols, you can use finger occlusion, capping techniques, or a speaking valve to facilitate speech. In decannulation, it is important to maximize the volume of airflow through the larynx or vocal cords. To maximize airflow, the tube may be downsized to increase airflow around the outside of the tube. In some cases, the use of fenestrated tracheostomy tubes may be beneficial in speech and weaning. Fenestrated tubes may provide additional airflow through the upper airway. However, positioning is critical in preventing complications. For patient safety reasons, speaking valves are not recommended for use with cuffed tubes. Tracheostomy patients need to be taught how to take care of themselves. Their caregivers and families can assist in this learning process. Clinicians need to teach patients wound care, tube care, and how to safely change the tube. The patient must learn self-suctioning, coughing, and deep breathing, and how to secure the tube to his or her neck. It is also important to prepare patients for emergencies. The nurses and therapists should provide hands-on, supervised practice time to help the patient and family gain confidence before discharge. In addition to these steps, patients should be provided with nutrition support and counseling. Use every opportunity for patient teaching, including during routine tracheostomy care. Proactive tracheostomy care can reduce the risk and occurrence of complications and promote positive patient outcomes. Coordinated discharge planning and home care teaching will help to successfully transition the patient from hospital to home. Nurses and respiratory therapists can play a crucial role in developing evidence-based practice standards and protocols for the care of the patient with a tracheostomy. Working within your facility to establish these standards and practices can help you to deliver excellence in tracheostomy care. Remember, confidence and competence equals improved care. For additional information about all of our tracheostomy products, please visit our website at medtronic.com.